My name is Jana Williams. I worked at PI for 30-some years as a research scientist in the biometrics research department. And I worked with, alongside of, and was married to Bob Spitzer, who was a PI for 50-some years as a research psychiatrist and the head of the biometrics research department. And I'd like to acknowledge Dan Spitzer, who's one of Bob's 5 kids, his son. Happy he came. I'd like to thank all of you for coming and tell you one little story. When our kids were little, Bob, who was very dedicated to facts and truthiness, he told our kids that there was no Santa Claus. So I was furious because Christmas has always been my favorite holiday. We argued about this for years. So Bob passed away 3 years ago on Christmas Day, and we always think of that as his final Jewish revenge. So with that, and because there are so many young people here who didn't know Bob when he worked here, I asked Michael first to say a few words about Bob, who he was, and the kind of work that he did. So he will do that, and then he will introduce the speaker, Jerry Wakefield. Thank you for coming.
So good morning. This is the 3rd annual Robert Spitzer Memorial Grand Rounds, and these are grand rounds where we're inviting people to talk about topics that would be near and dear to Bob's heart. So let me just start with a little, for those of you who aren't familiar with Bob, but even those who are. I worked with Bob for many, many years, and along with Janet in the department. And I would, among other people, I would consider Bob one of my most important mentors. So Bob received a bachelor's degree in psychology from Cornell University in 1953 and a medical degree from New York University School of Medicine in 1957. He completed his psychiatric residency at PI in 1961 and graduated from the Columbia Center for Psychoanalytic Training and Research in 1966, a fact that many people might find surprising given his eventual antipathy towards psychoanalysis. Dr. Spitzer completed his residency at Columbia and was a member of the faculty of the Columbia University Department of Psychiatry in the Biometrics Research Department at PI, and he retired from Columbia University in 2003. The seminal achievement of Bob's career was the establishment of a psychiatric diagnostic system that was empirically based on uniform standards. Psychiatry was at a crisis of credibility in the mid-'70s when Bob Spitzer was asked to oversee an update of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. 2 studies published in the early 1970s shook the medical community's confidence in psychiatric diagnosis. In 1972, researchers compared diagnostic practices among clinicians in New York and London and found that the same patients who were diagnosed as having schizophrenia in New York were being diagnosed as having manic depressive disorder in London. And Bob was actually a member of the steering committee for that study. The following year, Daniel Rosenhan published a very controversial paper in Science describing how 8 pseudo-patients were admitted to psychiatric wards for an average of 19 days despite behaving as normal after a single initial claim of hearing a voice. Bob wrote a scathing critique of Rosenhan's experiment. Quote, "A careful examination of the study's methods, results, and conclusions leads me to a diagnosis of, quote, logic in remission," which is, Bob always had a turn of phrase that was very pithy and right on the mark, but recognized that both the reliability and validity of psychiatric diagnosis was rightfully being questioned. Bob has devoted his early research career to developing questionnaires and interviews to measure psychopathology, culminating in the development in 1968, along with Jean Endicott, with the research diagnostic criteria and its companion interview, the Schedule for Affective Disorders and Schizophrenia. Again, with it's called SADS, S-A-D-S, always the great acronym from Bob. Bob's exceptional intellectual, organizational, editorial, and political skills were put to the test in the production of DSM-3, which required the development of operationalized diagnostic criteria for every disorder in psychiatry in the face of opposition by the then prevailing psychoanalytic community. A field trial which demonstrated that clinicians could use the DSM-3 diagnostic criteria to achieve good diagnostic diagnostic reliability resulted in its widespread acceptance by both researchers and mental health practitioners in the United States and internationally. Among the new diagnoses, championed as part of the DSM-3 process was post-traumatic stress disorder, which was added in part as a response to its increased recognition of the psychological sequelae of combat exposure among veterans returning from Vietnam War. Bob also played a major role in having homosexuality removed from the 1974 printing of DSM-3. After meeting with gay rights advocates in the early 70s, he began re-examining homosexuality based on whether it caused any measurable distress, which will be part of the topic of today's Grand Rounds. The issue was extremely contentious, but in 1973, he engineered a deal by which the diagnosis was replaced by sexual orientation disturbance to describe people whose sexual orientation, gay or straight, caused the distress, making it clear that sexual orientation in and of itself was not the grounds for a diagnosis of a mental disorder, paving the way for the eventual societal acceptance of homosexuality as a normal variation. Other achievements from Bob included the development of the structured clinical interview for DSM-4, known as the SCID, which has become the most widely used structured diagnostic instrument for research, and the patient health questionnaire called the PRIME-MD that is now widely used in primary care medicine for the screening and diagnosis of depression and for monitoring response to treatment. So today's Grand Rounds will be given by Jerry Wakefield. And Jerry Wakefield has worked with Bob and me for a number of years, so I think he is a particularly appropriate choice to give this Grand Rounds. So Jerry Wakefield, PhD, DSW, is a university professor, professor of social work in the Silver School of Social Work, professor of the Conceptual Foundations of Psychiatry in the Department of Psychiatry in the School of Medicine, and associate faculty in the Bioethics and the College of Global Public Health at New York University. Prior to coming to NYU, he held faculty positions at the University of Chicago, Columbia University, and Rutgers University. Dr. Wakefield's recent work has focused on the concept of mental disorder, the validity of DSM diagnostic criteria, and epidemiological analyses exploring the relationship between grief and depression. He has published over 250 theoretical and empirical scholarly articles in chapters in psychiatry, psychology, social work, and philosophy. His co-authored book, The Loss of Sadness, was named the best psychology book of the year by the Association of Professional and Scholarly Publishers. His most recent book is Freud and the Philosophy of Mind, published in November by Palgrave Macmillan. So let me introduce Jerome Wakefield for today's presentation, perhaps the longest title of a Grand Rounds, but you really know what you're going to get here.
Well, I apologize for those of you who found the title to be too much homework to read through, and it's slightly maybe hyperbolic, manic-y type, nature. But I thought that it would be good to, in the title, to give a sense of the importance of what we're about to discuss, in my view. So first, I just want to thank, obviously, the Institute, and thank Michael and Janet, thank Jeff Lieberman for the invitation to do this talk. It's very meaningful to me. I worked with Bob I had an appointment in the biometrics unit that he directed for about 15 years. I had an appointment there for about 15 years, and worked with him. We co-authored a bunch of articles together, and it's personally meaningful for me to try to present part of his legacy, and as I'll discuss, part of his legacy that isn't discussed all that much. And that has to do with the concept of mental disorder. So let me start with some broad strokes before zooming into nitty-gritty conceptual details. Bob was, as I said, for many years chair of the biometrics unit here. He died about 4 years ago. I've got that right, 4 years, I think so. 3 years ago? Huh. Sorry. So, and I'm going to use his name, Bob, because that's what I feel comfortable with. And this is going to be about him, not just in honor of him. And as I said, I'm going to discuss the concept of mental disorder. Now, this isn't the thing that comes to mind when people think of Bob Spitzer. The two things for which he's probably best known are, as Michael mentioned, the impact on the modern system of operationalized DSM diagnostic criteria, inaugurated with DSM-3 in 1980. Vast implications for the mental health field, not just psychiatry, but mental health and beyond mental health. And second, his role in the historic 1973 decision by the APA, that's 45 years ago as of 3 days ago, to eliminate homosexuality per se as a listed DSM category of disorder. Now, these are amazing legacies. It's worth saying that both of them have become contested in various communities. Subsequently, I'm not going to be discussing going forward. I'm going to be looking at a period when he was doing these analyses, so I'm not going to be carrying this forward to now and discussing many of the complexities of the debate today. But it's worth mentioning at the outset that in the case of diagnostic criteria, those operationalized criteria that you dutifully look up each day to make sure you've got every criterion covered in a diagnosis, many people in the mental health field, especially in psychiatry, and we saw that with the DSM-5 aspirations for a paradigm shift, are interested in moving beyond the symptom syndromal approach to diagnosis that Bob put in place. And people would like to go on to biological markers and ideologically anchored categories. There's a longing for a paradigm shift in a way. But as a DSM-5 effort suggested, we don't seem to quite be there yet in terms of the ability to make that happen. And paradigm shifts don't happen purposefully. That's one thing Thomas Kuhn taught us. Paradigm shifts are surprising, sudden, and they're kind of disorienting. It's not like you sit down, everybody who writes a paper today says this is going to be a paradigm shift. That's not how it happens. As far as the elimination of homosexuality, of course, that will stand as an amazing accomplishment. But subsequently, and a lot of people see, you know, all the efforts of the gay activist movement, of other legal and social actions, all of it contributed. But there is a kind of straight line from that decision, depathologizing homosexuality, to the utterly different world we live in today, totally different world when it comes to homosexuality. So there's more progress to be made, but that was a pivotal moment in what's happened. Now, despite that, in terms of contested legacies, Bob's subsequent work included a study of whether people who reported undergoing conversion therapy actually changed at all, and this has tarnished his legacy within the gay community, certainly, and actually made him a target of ambivalence or worse. So that aspect of his legacy forwarding has been discussed, and he in fact retracted and apologized for that study. I'm not going to be discussing that today. That's way past the period that I'm going to be focusing on. The lesser examined aspect of his work and is interesting because in a way this aspect that I'm going to focus on today actually links together the two aspects that I just discussed. It's his 8-year effort from about 1973 to about 1981 to formulate and understand a definition of mental disorder that would provide a conceptual foundation for psychiatry as a medical field. This is a pretty chutzpah type undertaking to provide a definition for an entire profession. This definitional effort links Bob's broader agendas in the following way. He was faced with the need to justify his position that homosexuality is not a mental disorder, And that triggered, he didn't have an interest in this topic before about 1973. He was doing things that might have led to such an interest. He was trying to create computer programs to guide diagnosis, which requires operationalized criteria and thinking about what the program should identify as a disorder. But he hadn't really engaged, as far as I can find, the question of what is a mental disorder. It's the issue of homosexuality that engaged his interest in this topic of what is a disorder, because, very simply, that was what the debate was about. The debate was about, is homosexuality a mental disorder? And Bob felt that whatever the other arguments, there were many arguments, obviously, around about pragmatic arguments, civil rights arguments, all sorts of arguments about why to depathologize homosexuality or keep it in the manual. Bob, as a nosologist and intellectually rigorous person, said really, in the end, the only way to answer this question is to provide a definition of mental disorder and show that this condition does not fit under the definition. And that is what he set out to do. Now, the definition also links to the broader DSM project in the following way. If you're creating operationalized diagnostic criteria for mental disorders, as Bob was doing post the developments that Michael described, post finer criteria, the RDC, they'd already formulated some criteria, and then Bob built on those for DSM-3. If you're doing that, you have to have some guidance as to what criteria make a disorder versus a non-disorder, because anything can be put into criteria. Any negative condition can be criterialized and then potentially seen as maybe a disorder. There was an article way back when people were debating the DSM criteria approach. Somebody, Jordan Smoller, who at that time was a medical student, and now he's an eminent behavioral geneticist at Harvard. He wrote an article about childhood being a disorder, and it starts with the inevitable statement, childhood has not been given enough attention as a potential pathology, and so on, and we need to pay more attention to this. And then he created a list of criteria, extreme dwarfism, labile emotions, and so on. And his point was, you have to know what a disorder is before you put down the criteria, because the criteria can be put down for anything. So the concept of disorder, in a way, is a regulating principle for DSM's criteria sets. And DSM-5 made that explicit. It says, if you look in the introduction, it actually says, this definition of mental disorder must apply to all categories in the manual. That's a remarkable statement. It means here's an additional constraint on every single disorder in this manual. Now, at Bob's time of dealing with this, there was a much larger issue than just the depathologization of homosexuality, as large as that was. The issue was the anti-psychiatry movement, which was really taking a toll on psychiatry. It may be hard to imagine now. Part of the reason it's so hard to imagine now is because our profession has such a reasonable amount of esteem and security and power and so on. In a certain sense, Bob, I think, one can debate this historically, but I think Bob's attempt to address the anti-psychiatry movement through the DSM's criteria and the definition of mental disorder actually was pivotal in defanging that movement. And really, people pop up once in a while, but today there is no anti-psychiatry movement as such. There are critiques of specific, you saw at DSM-5, there's no lack of intra-professional arguments about the validity of various categories, but there's no global argument like the anti-psychiatrist made that the mental health field is a bogus medical field. It's not medical, it's really social control, and so on. Yeah. Okay, sure. Well, yes. I meant it as a comparative statement. We had, in those days, yes, no, I totally agree. There's horrifying things. Okay, much diminished is a definite accepted amendment to that. I mean, in those days, you've got to understand that around the same time that all this was happening, insurance companies actually cut down reimbursement for mental health treatment. If you look at the statistics, this is remarkable, actually, what a toll all this was taking in terms of public esteem down, in terms of applications for residencies and other kinds of post-training positions in psychiatry. The applications were way down. So this was taking an enormous, real, pragmatic toll. Hopefully the toll of Scientology will stay on the wear and tear on Oprah's couch or something like that. In any event, the Odyssey, the conceptual Odyssey I'm going to describe today, I have 5 anchor points. Honestly, the details are interesting. I don't know if I'll get to every one of these anchor points, but this is the development of his views that I kind of constructed. 1973 was the statement accepted by the APA, which included a definition of mental disorder, that actually took homosexuality out of the DSM-2. That statement on it I'm using was published in AJP, American Journal of Psychiatry, and that's generally the reference, but it was also put into the DSM in later, DSM-2 in later editions. A few years later, Bob co-authored with Paul Wilson a handbook entry on the concept of disorder, and that has a few additional twists and turns, but it's basically the same idea. There wasn't really a new vision. One of my points that I'm going to make today, and let me make it right now, is that conceptual analysis is methodologically its own game. It's a difficult game. It requires the same thing that scientific theorizing requires. It requires an open mind and looking for counterexamples, looking for tests. You've got to be sort of Popperian about it. You've got to look for where your account falls down. Otherwise, you see things that are in common to a class, you say that's the definition. But it's not, because you haven't looked for counterexamples. So I'll be, up till 1975, Bob was mostly concerned with making sure that he had a definition that eliminated homosexuality from the manual. That was his primary focus, and that kind of shaped his definitions. But after that, he started realizing, and it's about then, in 1974, that the DSM-3 task force was formed. And once he got onto that task force, as chair of that task force, he saw that the definition of mental disorder had a vast realm of issues that it could be applied to. And so as of around that time when that was published, it was written a little earlier, obviously, Bob started on the road to becoming truly a conceptual analyst in the philosopher sense, where he wanted a general account that wasn't just tied to the goal of getting homosexuality out of the manual and keeping it out against various objections and onslaughts and so on. After a lot of internal process in APA and objections to various things, finally he and Gene Endicott published a classic article in 1978 giving a whole chapter, the previous definition has been one paragraph, a whole chapter analyzing mental disorder. It's probably the most sophisticated effort that he made. It's one of the most sophisticated efforts in the history of thinking about this topic. It remains so. And we'll get to that. And there's several new moves there. And then onward to the DSM-3 definition of mental disorder. His colleagues at APA didn't like such a long definition. It would have been really absurd to put it into the introduction of the DSM. I think in retrospect, the whole idea didn't make sense. And Bob worked on whittling down the essence of the definition. And in doing that, he actually improved it, I'm going to argue. And so that's what appears in DSM-3. And then I'm going to make quick reference, if we make it that far, to a 1981 article in which Bob, after all of this, reflects back on the homosexuality debate and thinks afresh about what it is to be a mental disorder, how you argue in such a case, and comes up with a very clear and rather surprising answer to that. So I'm not going to do every single slide, I think, to make sure that I can make it through most of the material. Controversy was raging as to whether homosexuality, and we're in 1973 now. To keep a timeline, most of the slides have roughly where I am in this process up in the top left corner. And he explained, this controversy rages as to whether homosexuality should be regarded as a pathological deviation of normal sexual development, which certain psychiatrists had staked their careers on and did research on and had theories of and so on, or it could be a normal variant of the human potential for sexual response. And the controversy after around 1970, the controversy spilled over to the APA, not internally, but also gay activists were forming protests at APA meetings, forming chains of people around the meeting hotel, and so on and so forth. Bob, of course, this is totally characteristic of Bob. Bob, of course, rather than rushing through the lines at one conference, stopped and talked to people and asked them to express their views. This is such a remarkable thing. He actually, I mean, this is just one fact about him, no matter how much he felt he was right about something, he always wanted to open himself to dialogue with people who thought differently, and he would actually listen. And that's what he did in this instance with the gay activist demonstrators. And he came away convinced that there's something wrong here and that he should look further. He invited them to a meeting of the Committee on Nomenclature and Statistics, of which he was a member. He invited a group of gay activists to visit that committee. And after that, he planned and actually organized a debate, a famous debate at the next APA meeting. Now, at that APA meeting, after that debate, I think it was Harold Gold, I think was his name, was one of the debaters, took Bob, he was a gay, he wasn't a psychiatrist, journalist, but he took Bob to a meeting of closeted gay psychiatrists who were leaders in the field, most of them, or several of them. Bob was shocked, I think, to read his accounts later. And you can almost see in this moment what led to the definition that he gave. Because other than the really wonderful studies of Evelyn Hooker and others who had shown that there really psychologically is no distinction between gay and straight people on psychological tests and symptoms and so on, the standard view was that homosexuality was a pathology that was infused throughout the personality and made it difficult to accomplish things socially, occupationally, and whatever. Here Bob is sitting with some of the leaders of the field. They called themselves the gay PA. And he's seeing people who are obviously totally comfortable with their sexual orientation, no distress, seeing people who are high achievers occupationally and socially. And he must have said to himself, "What? This is just not a disorder. This isn't something that is, in fact, impairing these people." So, now, he just describes it later. The issue was, should homosexuality continue to be classified as a mental disorder? And that's why he had to come up with a definition of mental disorder. The way he saw the argument, it had to do with the concept of mental disorder. There was no way out for Bob of that. Now, in fact, what happened was that very night, this is astonishing, that very night that his eyes were opened at that meeting in Hawaii, this is sort of hard to imagine with, they describe it in various histories with grass-skirted, waitresses and these large, colorful Hawaiian drinks and all that. And this Momentous discussion is taking place, and Bob immediately that night went back to his hotel room and drafted the proposal for eliminating homosexuality from the DSM, including the definition of mental disorder that we're about to look at. Now, doing conceptual analysis on the fly like this is pretty daunting. But I just want to say, as a little bit of an aside here, and again, we'll get into the hyperbole realm perhaps for some of you, but it is something that leading scientists do every once in a while when they feel their field is stymied or limited by the conceptions they entertain, and that if you go deeper and look at the real meaning of the concepts underlying the field, the foundation, that you might be able to open up a space where there's progress. So, with thanks to my graphically talented assistant, Jordan Conrad, here's Socrates started it all. Socrates asked, what is virtue? And he came up with a theory that to this day many people hold, namely, virtue is actually a cognitive function. It's knowledge of what you should do, of what's good. So, for instance, he asked the general, actually it should be the other way in a way, but what is courage? And, of course, this is why they put him to death, because he embarrassed everybody, all the experts. Because, of course, the general really had no idea about courage. The general said something like, courage is where you forge ahead in battle. And, of course, you know, now we get to counterexamples. This is what Bob had to learn. Counterexamples are the critical tool of the methodology of conceptual analysis. What did Socrates answer? He answered, so are you saying that if somebody retreats in an orderly way, holding off the enemy as they try to take you from behind, but holding them off, that that's not courage? And the general had to think and say, oh, I guess that's courage. And what about in politics? What if somebody risks their entire future by stating the truth? Is that not courage? So through counterexamples, you show that the concept goes deeper than people think initially. And cognitive scientists have shown over and over, we're not very good at looking inside and deciding what concept we're using in making our distinctions. That's why conceptual analysis, a systematic approach of theorizing about it and testing the theories, is useful. Well, you know, Charles Darwin, what is teleology without God? Turns out to be natural selection. Freud, what is a mental state? He came up with an interesting answer. If you want the answer to that and you want to see how Freud got there, oops, yes, that's a new book out by some guy at NYU that discusses that very point. But most of all, of course, the person I'm most familiar with is Einstein. Einstein famously stopped all the physics for a few minutes and thought, what do we mean by two things happening simultaneously? What does it actually mean in physics? And out of that famous discussion, as many of you have been through the train example, I won't go through it, but the point is, out of that thinking comes his ability to create the equations of special relativity and transform the world. So it's not unusual for leading scientists to step back and try to think about a foundational assumption, and that's what is mental disorder? Bob joins this distinguished company. I've talked about that. Now, I think it's good to think about what Bob was trying to do in the conceptual analyses we're about to review. If you look at the statement he made later on in 77, these principles, or the analysis, help to avoid an overly broad definition of mental disorders that would view all individual and social unrest or problems of living as psychiatric illness, and at the same time justify the designation of mental disorders as a subset of medical disorders. I would say that for people engaged in this enterprise, at least within the tradition that Bob and I share, those are two constraints on a successful analysis. If you can't do those two things, you don't really have an analysis of mental disorder of the kind we're after. You have to do two things. With the Soviet hospitalization and treatment of dissidents in mind for sluggish schizophrenia, the use of, in other words, psychiatric diagnosis for social control purposes in mind, one thing a good definition has to do is give you some boundary. It can be fuzzy. Concepts are fuzzy. You'll never be able to tell me exactly the difference, exactly the cut point between night and day. You won't be able to tell me the cut point between adult and child, but those are both legitimate distinctions because they show clear cases on either side that we can talk about. So it's okay if it's fuzzy, but it's got to also have some clear cases on both sides. The anti-psychiatrists, of course, thought there's no distinction. Mental disorder is just socially undesirable behavior. So if you can do that, that's a big plus. That gives you a wedge against anti-psychiatry. And similarly, the second one, it's not just that you can tell how far psychiatry goes, but you can place it within the medical field, because that was the other great argument against psychiatry in those days, that it's not really a medical discipline, it's just a social control discipline or a social discipline of some kind. Those are the two things. More generally, obviously, Bob kept his eye on the homosexuality dispute all the way through, all 8 years. Whenever he did something new, he would look at it and make sure that it didn't undermine his case that homosexuality is not a disorder, because that was his strong intuition. And obviously, it has to explain most of our consensual judgments about what conditions should be included as DSM categories. Where these intuitions diverge is where we get all those controversies, like we saw with DSM-5, a whole series of controversies about whether these things are really disorders or not. And even if, and so those two, and then the rest of these, and you can't solve disputes. People often say, well, a concept of disorder, if you can define it, will solve all our disputes about what a disorder is. No, it doesn't solve that. It may explain why we differ. It may explain the facts that we're assuming that make you think one way and me think the other. It may explain the values we don't share that makes me think this is harmful enough to be a disorder and you not. It needs to explain these things. So for instance, it may explain why some people think that certain cases of ADHD aren't disorders, because in their minds they theorize that this is natural male boy behavior or whatever. That would explain why they think that. It's a fact of the matter whether they're right or not. Whereas other people think, no, something's gone wrong with brain functioning in such a case. That explains why they think it's a disorder. So it's got to explain, but it doesn't have to resolve, because resolution requires science, research, a theory. A lot more than just a definition of mental disorder. I just want to make one caveat point here. The definition of mental disorder doesn't determine who gets treated in Bob's view. He had one nice little comment, which he actually titled, "Diagnosis and need for treatment are not the same." So I want to just emphasize this is not about who can get treatment. If we look here, this is a diagram by Clareman and Schechter, which was supposed to show the many goals of psychiatry. And as you see, and I think Bob would basically agree with this, you have to define the core of mental disorder that justifies the field being a medical field. But the mandate for the field then uses those tools and goes way beyond that. Coping with stress and distress, which is normal. A normal range issue for people, but it can be extremely painful, enhancing human potential, and so on. So what you need is this definition of the core, but it doesn't limit you in scope. And Bob always pointed to the V codes, which are non-disorders that are often seen by mental health professionals as evidence that the DSM did not try to limit the scope of treatment in this way to just disorder. Well, when Bob's proposal was accepted and then published, it was big news. Here's the New York Times in '73. And here you see in the lower left-hand corner, on the front page, psychiatrists in a shift declare homosexuality no mental illness. So it's interesting that Bob also urged the APA's Board of Trustees that they should pass a resolution supporting gay rights, and they did, civil rights. And they passed quite a strong resolution. It's interesting that Bob had to put a little caveat in his paper because he thought that the fact that they linked civil rights to depathologization could have a boomerang effect where people said, oh, so that means that if it's a disorder, we can deprive people of civil rights, right? You're saying that you have to depathologize to gain civil rights. So he put a little caveat saying this doesn't imply that, but pragmatically this has been used to deprive people of civil rights. Okay, what was a definition already? Here it is. That's it. This little definition is what changed the course of American history in a way. For a mental or psychiatric condition to be considered a psychiatric disorder, it must either regularly cause subjective distress or regularly be associated with some generalized impairment in social effectiveness or functioning. That's it. Now, as Bob, I'll come back to that in a second. This is actually a very strong definition in one way. Let's look at that. Generalized impairment in social effectiveness or functioning is remarkably strong. Generalized impairment? How many of your patients, for some of you, it may be 100%, but for most of us, even our patients who have disorders aren't suffering from generalized social or occupational impairment. They're suffering from focal impairments that are justifying of a diagnosis of a disorder. So this is quite a strong condition, either distress, or if there's no distress, then generalized impairment. Now let me emphasize that I think Bob was here at the beginning of a process. He really wasn't doing systematic conceptual analysis yet, and there are many flaws in this definition, obviously. I'm sure he would agree today, given what came later. First of all, notice that this is posed, it's talked about as if it's a definition. A definition is always a necessary and sufficient criterion. So if you meet it, then you have a disorder. If you have a disorder, then you meet it. It's like two equivalent sets, the definition and the set you're interested in this case, disorders. But there's just no way that this could be a sufficient criterion. Distress is not sufficient for disorder, let's face it. Unfortunately, life is filled with distress that is not disordered. And in those bigger circles that Klerman and Schechter's diagram contained, and all of us are subject to it. Now, if you look carefully at the wording and want to be charitable, and I always do believe in being charitable when you're analyzing somebody's text, Bob's statement there does not actually hold sufficiency. If you look at the wording, it says, for a mental or psychiatric condition to be considered a psychiatric disorder, it must either regularly cause distress or generalized impairment. Must is a necessity term in logic. So if we take it that way, that reduces some of the jeopardy logically of this definition. It's a necessary condition that you have one or the other of those two things. Now, why do you have to, if you don't have distress, why do you have to have generalized impairment? That's, as I said, very strong. And the reason is very simple. This is where Bob's definitional efforts were, I'll use a strong word, distorted, or by his absolute commitment to make sure that there was no question that homosexuality was eliminated from the manual. What he saw was that the main argument against him was, but look, people who are at least exclusively homosexual are impaired in an area. They're impaired in heterosexual sexual relationships. So that justifies, that impairment justifies a diagnosis. And Bob evaded, instead of actually undermining and completely answering that in a way that made it go away without having to do anything difficult, he realized that the easiest way to get rid of it was to require generalized impairment. Because the one thing that was clear was that even if one could argue, if one argued, not that he would agree, but if one argued that exclusively homosexual individuals are quote unquote impaired with respect to heterosexual relations, that's still a very local, specific, focal impairment, and it wouldn't meet this definition. So that's why this strong criterion. Now, we'll see in a few minutes that, he had to give that up. It doesn't make sense. It's just much too strong. It would denude the DSM of many, many conditions that are focal, that have focal impairments. And eventually he finds another route. And so his support for the definition was the claim that, well, everybody, all the conditions in the manual, except for homosexuality, have this feature. I don't think that's true at all. Everything, I mean, you start listing erectile dysfunction, selective mutism, bulimia, intermittent explosive disorder. Those are all disorders, but none of them are necessarily generalized social or occupational impairment. I think he was reaching here. So, now, Bob actually takes up the objection that you don't need to have a generalized impairment, that why don't we make it just local impairment? And, you know, he says, okay, leaving homosexuality aside, could that be a way to go? And he offers a series of counterexamples to that. If failure to function optimally, that is, in some important area of life, that's the key phrase he used to use, in some important area, like meaning more specific area, as judged by either society or the profession, is sufficient to indicate the presence of a psychiatric disorder, then we will have to add to our nomenclature celibacy, because that's failure to function, so revolutionary behavior, religious fanaticism, racism, vegetarianism. Times have changed, and male chauvinism. So his point is, if we weaken the criterion to allow focal impairment, then it opens the door to pathologizing all sorts of things. Now, again, I would say, with all due respect to Bob's earliest efforts, this is a fallacious argument. The reason we don't pathologize all the things on, oh, by the way, this is not a theoretical argument entirely. People had been pushing to get racism into the manual repeatedly. And also, it's not on this list, but marital conflict and other distressing and impairing kinds of conditions that nobody considers disordered, people had pushed in order to get reimbursement, in order to broaden the diagnostic field, to get these into the manual. And Bob held his ground, stood his ground, and did not allow it, because as you can imagine, if he had allowed any of that, nice socially as it would have been, his argument against the anti-psychiatrists would have gone down the drain. So he felt very strongly that the bigger purpose was served by being conceptually rigorous. But the reason that none of these conditions are disorders doesn't really have to do with whether the impairment is local or generalized. It has to do with the fact that we think that these are things that happen within normal range. People can become celibate and not have anything really wrong with their minds or brains. People can take up vegetarianism and actually not be pathological, and so on and so forth. So there was something missing here, and he didn't realize that at this early stage of his work. But even in 1973, he understood that that the big game was anti-psychiatry, because he says in that statement, we will no longer insist on a label of sickness for individuals who insist they are well and who demonstrate no generalized impairment in social effectiveness. We will thus help to answer the charge of some members of our own profession who claim that mental illness is a myth, Thomas says, and that by labeling individuals with psychiatric diagnoses, we are merely acting as agents of social control. That's the big game he was playing. He later admitted that this necessary criterion didn't really work. In several places, but here's a statement from a 1997 commentary. Perhaps motivated to find the necessary criteria for classifying condition as a mental disorder that would justify removing homosexuality from the official list of mental disorders, I argued that virtually all of the mental disorders, had this features. But he also is aware that there are counterexamples. He recognized later that if the concepts used to resolve the homosexuality controversy were applied to many sexual deviations, such as necrophilia, sexual attraction to dead bodies, and pedophilia, these commonly accepted mental disorders would only be considered illness if the individuals with the condition were distressed by them. And that's not a satisfactory state of affairs, nosologically, from Bob's perspective. And in addition, the early definition that we just looked at it doesn't make it clear why normal bereavement, which has a similar clinical picture sometimes to mild depressive disorder, is certainly distressing, often generally impairing for some period of time, shouldn't be considered a disorder, yet it's not considered a disorder. So as he went on, he became more of a philosopher. This is the philosopher in Bob, looking back and saying, not just, how can I make this happen of getting rid of homosexuality from the manual, what will work? But saying, systematically I'm going to test this against possible counterexamples and see where its weaknesses are, see where I've made a mistake and it has to be improved. And that philosophical or conceptual superego takes a while to develop. When you teach it in courses, you see students actually working to figure it out. You ask them, what's a bachelor? And people say, an unmarried male. And then it takes them 5 or 10 minutes for somebody to say, well, wait, a child that's an unmarried male isn't a bachelor. This must be more complicated than that. Or, oh, wait a minute, what about a widower? That's an unmarried male, but not a bachelor. So it takes a while. There's a learning curve. In 1975, where, as Michael mentioned, Bob's mind was on anti-psychiatry, very full of anti-psychiatric arguments. Here's the article that Michael mentioned where he answered Rosenhan, which was Rosenhan's study was extremely influential and embarrassing. And Bob took a lot of effort to really take it apart. But he basically went over the same ground as in the earlier definition with some additional twists. Now, here's something interesting. In the course of the 75 article where he repeats his earlier definition of mental disorder, sort of offhand, they give a definition of medical disorder. It's parallel to mental disorder. He's not saying mental disorders are necessarily like to be subsumed under medical disorder. That's what he believes. But he just gives this definition in parallel, separately. And he defines it as, and he explains, well, no definition of medical disorder is needed. Everybody knows what it is as far as physical disorders go. And here's their definition, Spitzer and Wilson. Medical non-psychiatric disorders are conditions associated with physical pain, disability, or death. Now, again, 75, he still is developing as a conceptual analyst. Anybody who's thinking conceptually will look at that and say, well, that's obviously not quite right. Something's missing because there's extreme pain in many situations. There's even disability under some normal conditions, maybe fatigue, sleep, childhood, and so on. Physical pain, childbirth pain, and so on. So these are all, this definition is, again, like the early definition of mental disorder, wholly inadequate to actually explain to us how it is we make our judgments of disorder and non-disorder. He has a lot of conditions. I'm not going to go through all of them. He mentions there's the issue that not every disorder is causing harm right then and there. It may have to develop, like a neoplasm that you discover on X-ray, but it hasn't developed to the point where there's symptoms yet. So it has to, in the full-blown state, it would cause these harms. He puts in as a way of conceptually getting it tighter. And used the phrase regularly associated with. And there's other qualifiers. I'm not going to go into them right now. What I want to just say is one more thing about the 75 paper. Bob, now after this, he really develops quickly as a conceptual analysis, but at this point, he's still not seeing the systematic counterexample methodology of conceptual analysis that gets you further. In the very article he wrote with Wilson, there are ample counterexamples to the very definition that they present. Namely, they survey the DSM domain of disorders, and at the end, they have the V-code domain. So Bob and Paul actually discuss the V-codes, and the V-codes are indeed conditions that can cause intense distress, but are not considered disorders. They're counterexamples to the very definition we saw, and it's right in the same chapter. So the systematic nature of the conceptual enterprise has not yet fully appeared. In 1978, he finally sees how conceptual analysis needs to be done in a systematic way that leads him much deeper and to a much more sophisticated definition. First, I want to mention, at the time of the 1978, I should say I did a critique long ago of this article, but today I'm going to focus on what I see as an advance in it. Let me first say 1978 was a remarkable year for the history of the foundations of psychiatry. Obviously, there is this article that I'm about to discuss, Medical and Mental Disorder, Proposed Definition and Criteria by Spitzer and Endicott. The very same year, Gerald Clearman published The Evolution of a Scientific Nosology, which is generally taken to be the statement of the neo-Krepelinian agenda and approach to reduce all psychiatric disorder to brain disorders. RDoC is, you might see it, I mean, one could debate this exactly historically, but you could see RDoC now as a belated attempt to go back and try to revive this. But that was very influential. And he actually stated like 9 principles that anyone who's a neo-Krepelinian and believed in the scientific status of mental disorder would adopt. And Sam Sam Guzay published that same year Why Psychiatry is a Branch of Medicine, doing what Bob's trying to do. But Guzay does it in a very different way. He says the medical model is what general physicians use. If we use it and consider all mental disorders brain disorders, then we'll be part of medicine. And that's the way you have to do it. Now, Bob realized in '78 that he had made a mistake in the earlier versions, that the whole game of putting mental disorder within medicine meant that you had to have an analysis of medical disorder in order to accomplish your goal. And so that's what he set out to do, to analyze medical disorder generally, and then see mental disorder as simply a special case. Solve the equation for this variable, mental conditions, you get mental disorder out of the definition of medical disorder. Now, here was the definition he came up with. A medical disorder is a relatively distinct condition. That, by the way, goes back to the Robbins and Guzay 1970 article explaining how to establish the construct validity of mental disorder categories, in which they give a series of criteria, ranging from family history and phenomenology to biological markers and so on. So they put that in, distinct. It has to be established to have some distinct existence as a condition. But in any event, resulting from an organismic dysfunction, which in its fully developed or extreme form is directly and intrinsically associated with distress, disability, or certain other types of disadvantage. The disadvantage may be of a physical, perceptual, sexual, or interpersonal nature. Implicitly, there is a call for action on the part of the person. Now, this call for action, the more sociological aspect, I'm going to set aside, because in the text they actually say, well, the call for action kind of follows from the fact that there are these negative consequences for the person. So it's not as essential as the other aspects. So here, after all this effort, is what a mental disorder is. A mental disorder is just a medical disorder whose manifestations are primarily signs or symptoms of a psychological behavioral nature. Or if the symptoms are physical, they have to be understood using psychological concepts. So here you're thinking of conversion hysteria or something, somatization, where the immediate symptoms are physical, but the explanation routes its way through psychological meanings so that you can still consider it a mental disorder, despite no obvious disruption in psychological functions. They then proceed to give an operational definition that takes up most of the chapter, and I'm not going to be able to go through all of it, but they list the distress. There are three possibilities, right? Distress for harm, distress, disability, or disadvantage. Now, what is disadvantage doing in here? We haven't seen that before. Disadvantage is the way Bob now sneaks into the definition, if you will, the idea that, yes, I see it now. After trying to work on DSM-3, it's obvious. Many disorders do not involve generalized impairment. How do we get focal impairment into the definition without undermining the homosexuality decision? For those few people out there that are still objecting to that, and that's waned a lot, obviously, over the years, by 1978 even. But how did he do that? He did it by adding this disadvantage clause in which the disadvantages are basically specific impairments. And he said, if the impairment is important enough, it's an important impairment, then it can go under disadvantage, even if it's focal and local, and it's not generalized, and then you can use that as your harm. That's a major change. He's now admitting that generalized impairment is not necessary. And they actually list in this lengthy definition a whole series of actual disadvantages that they take to be warranting of a disorder label. I'm not going to actually go into them right now. And he sees at this point that his earlier definition was, as he calls it, rudimentary when he wrote the piece about getting homosexuality out of the manual, that it was just not really up to par. Now, here are the novel features in this new definition that all go together. For the first time, he is defining mental disorder as a form of medical disorder, thus directly addressing the anti-psychiatric critique that mental disorders are not medical disorders. Most importantly, in my view, he introduces for the first time the concept of organismic dysfunction as a fundamental requirement of medical and mental disorder. Up to now, as you saw in 73 and 75, it was all about harm, it was all about distress, it was all about impairment. Now, the distress or impairment has to be caused by something, this theoretical, vague, hypothesized thing that he called organismic dysfunction. And frankly, he admitted all the way through to a decade later, or more than a decade later, that he didn't really know how to theorize about organismic dysfunction. It was a bit mysterious what it means, but he knew that there had to be something going wrong. That was the intuition he had. There's something going wrong. It's not just that anything inside the person is causing this stress or impairment, that something is going wrong. Now, what the heck does that mean, going wrong? But that was the idea that distinguished the normal range misery from the disordered misery. So organismic dysfunction became basic. And he was quite explicit that this is fundamental, because trying to decide on all the conditions in the DSM-3, he must have realized that the load of conditions you can consider is way, way bigger than the ones that are disorders, and you needed a really strong criterion that explained why you choose only some of them intuitively as disorders. And the phrase "something has gone wrong" that's supposed to correspond to organismic dysfunction. And he he presents many counterexamples. He presents counterexamples to his own earlier definition of medical disorder. He says, pain during childbirth is distressing and painful. We said before that anything painful is a medical, so of course that's wrong. This isn't a medical disorder. It's something we want to treat, but it's not a medical disorder. So he's now working on all cylinders as a conceptual analysis, seeking out counterexamples. And thus, because of this, with organismic dysfunction, disadvantage, the border between disorder and normality becomes much, much more complicated. This is a diagram that was in an article he did with Janet, just illustrating, and I'm not going to go through everything, but illustrating all the domains in which disorder versus non-disorder cuts across some larger group. And so in every one of these domains, we have potentially fuzzy boundaries that need to be negotiated, thought out by people who are dealing with that domain to make a legitimate distinction between disorder and non-disorder. Now, I want to address two myths quickly. One is, a lot of people say, oh, Bob capitulated to the psychologists because they demanded that he not use medical disorder in the definition of mental disorder, which you just saw he did. That was central to this effort shortly before DSM-3. And they say, oh, he agreed after a year or two of quite irritating back and forth negotiation and argument. He finally said, okay, we'll take medical out. And some people say, oh, see, he capitulated and gave up on that to the psychologist. And the answer, briefly put, is nonsense. Bob was smarter than that. Bob understood that what mattered was not the word medical, which, he might have dangled it out there and taken it out as a strategy, actually. But what mattered was the definition. In the whole brouhaha about the definition of disorder with the psychologists, many psychologists were behaviorists, and you're looking at a definition that demands organismic dysfunction internal to the organism. That doesn't fit their theory at all. That's a medical concept. And Bob understood full well what others observing didn't understand. It didn't matter about taking the word medical out if his diagnosis, if his analysis of what a medical disorder is was correct. If that analysis was correct, then his definition already builds in that this is a medical discipline. And it doesn't matter whether the word medical is there or not. A second myth is, on the other side, the psychologists say, or the psychologists are a little bit too reductionistic, but many other people who are not biological psychiatrists say, oh, Bob's DSM was a biological psychiatry document, basically. Look, he had all those Washington University trained neo-Krepelinians on the committee that all said all mental disorders are brain disorders. And the answer here is this is absolutely not true either. Bob interacted strongly with the WashU folks because they had come up with the idea of operationalized diagnostic criteria, which he built on in the research diagnostic criteria and then in DSM. It's interaction with them that honed these definitions. They were the ones thinking about it. They're the ones that had first proposed this approach within research. And Bob transported it to the clinical realm. But he never, this is critical, he never bought the neo-Krepelinian argument that all mental disorders are brain disorders. It's not that he rejected it and said it's false. He just thought that the empirical evidence isn't in. We don't know. And so he never allied himself with the neo-Krepelinians on doctrine about psychiatry, even though he saw the opportunity and he used the criteria that they had come up with. And I think they themselves thought that they had triumphed somehow and won DSM. But in fact, it's quite clear, he says this over and over if you read his articles carefully, and right here, for instance, in the 1978 article, there is no assumption that the organismic dysfunction or its negative consequences are of a physical nature. He says again in 1982, DSM-3 makes no assumption that a biological abnormality accounts for each of the mental disorders. This denies the claim that Sam Gouset was making in that very article in the same year. That's exactly the claim he was making, and Bob is denying it. In fact, when he does get lumped as a neo-Krepelinian who's just focused on biological explanation, again, no assumptions made regarding the primacy of biological. It should be of biological over social and environmental. He's an integrationist. When he was accused of being a neo-Krepelinian and classified as being a neo-Krepelinian by Roger Blanchfield in a famous article, he actually wrote into the journal a letter to the editor stating that he hereby resigns from the neo-Krepelinian school. And he states several reasons, but one of them is, he states, look, the neo-Krepelinians, Klerman says that the neo-Krepelinians believe, quote, the focus of psychiatric physicians should be particularly on the biological aspects of mental illness, unquote. And then Bob says, nonsense. Psychiatrists should concern themselves with all aspects of mental illness, including the psychological and social aspects. I hope that my resignation from the Neo-Krepelinian College will be accepted, as I have already joined the faculty of a much larger institution of higher learning. The faculty of this university is multidisciplinary, and its credo is simple and easy to remember. It is data-oriented. He just wanted to find out the facts and not be part of an ideological movement that assumed things about the facts. Well, then we go on to 1980 and DSM-3. I'm going to have to move on because time is actually out. I am told that how he whittled down that long definition in 1978 into DSM-3, actually there was a lot of interaction between Bob and his wife, Janet, and well, never mind. I made a note to myself, neither the Russians nor the Chinese have yet released secret recordings of what must have been a fascinating year or two of pillow talk that yielded the DSM-3 definition of disorder. But we can at least examine the outcome. And the shift, and I'm just going to focus in on one shift. This is how science happens, and this is how conceptual analysis happens. You notice that in 1978, there's this unbelievably complicated definition. Just the harm, leave aside the organismic dysfunction and the full-blown and intrinsic and all those qualifiers. But you've got distress, generalized impairment, and then disadvantages that are important when they're more focal. And then you got this huge list of those disadvantages that justify disorder attribution. What a mess. Between 1978 and when I don't know, when 1979, I guess, whenever DSM-3 went to press, Bob saw the light and simplified it. It's very simple. Just think about it for a second. If important disadvantages are enough to warrant disorder when there is organismic dysfunction inferred, then generalized impairment is redundant. Because generalized impairment, you can be sure, involves some local impairment. So generalized impairment now just falls under important impairment in some function. And as long as it's now the organismic dysfunction criterion is doing all the work that Bob couldn't see how to do back in 73 and 75 of distinguishing the focal impairments that are disorders from all the focal impairments, racism, vegetarianism, whatever, that aren't disorders. It wasn't the nature of the impairment per se, as long as it's enough. It was whether they were caused by organismic dysfunctions. He sees that and simplifies everything. I think I'm out of time. Am I out of time? Way out of time. So I just want to say one more thing, that he, in the 1981 article that I can't cover now, unfortunately, Bob makes very explicit that what goes under the important disadvantages in this simplified definition of important impairments is a value judgment. Bob makes explicit that value judgments cannot be separated. And he realizes, going all the way back, that he's been making a value judgment in eliminating homosexuality from the manual, and that is intrinsic. It can never be eliminated from diagnosis. And I think that's one of the legacies that I don't have time to go into, unfortunately, but I want to leave you with, is that going forward, we are both inevitably, as a profession, dealing with things that we care about. We are inevitably a scientific research enterprise to look at the dysfunctions, the organismic dysfunctions, and we are a moral, ethical value enterprise that tries to understand what is bad and what's not so bad in life. Even though we're not trained in that particularly, we're making those judgments. They're in the background. They've been made by the framework within which we work, and so they're not visible most of the time. Thank you very much.
Thank you very much, Jerry. Let's, we don't have that much time left, but I want to open it up for some questions. Dr. Lieberman always gets the first shot.
Well, thanks, Jerry. It's like hearing this is like reliving history. And Bob Spitzer, there's a Mount Rushmore for, the evolution of psychiatry. He definitely has a place on it. But how are mental disorders and their nosology different from medical disorders, in the sense that all medical disorders started out with phenomenologic diagnoses: dropsy, falling sickness, diabetes mellitus, insipidus, and then when the pathology was revealed and methods to operationally define a test to confirm it, or even etiologies were done, then it moved on to a different level of diagnostic precision. So, I mean, we've gone through this tortuous process, which you very articulately described, but is it really any different? I mean, is it exceptional, or is it just that we're at a later stage? I mean, it's
an earlier stage.
An earlier stage.
Well, yeah, no, I mean, one way of looking at it is, first let me just say that Bob, and I agree with him here, downplayed the distinction between mental disorders and other disorders. You want to understand medical disorder, and we kind of pragmatically carve off mental disorders to some extent. But in terms of your question, look, Hippocrates could recognize a physical disorder, and he had no theories. He didn't know etiology, or if you read the theories he had, they were so wildly off that they certainly didn't help with diagnosis. If you think of psychiatry as at an earlier stage of development, Bob, actually, if you look in DSM-3's introduction, he said this. This is temporary. We are aspiring to move on to where the rest of the medicine, 2,000 years ahead of us, is now. We're not there yet, and while we're getting there, the best thing is bootstrapping ourselves by these criteria so we can study things. But he quite well recognized, and I think it's absolutely right, that there is no intrinsic difference in the process. Ultimately, we want etiologically grounded categories and not syndromal categories.
It was 1978. You think he thought we would have been there by now?
I know. Well, that's the impatience in the field, absolutely.
Dr. Warden, over there.
I'll be contemporary, Bob. And you're
Oh, it's not,
one of the stimuli for the creation of what ultimately became DSM-3 was the inability of researchers in psychiatry to talk to each other. That depression in St. Louis wasn't necessarily depression. And as a consequence, these criteria were established, and they certainly serve that purpose very well. But what concerns me is if in the teaching of clinical psychiatry, our residents are taught that if a patient only meets 3 out of 5 criteria, they're not depressed. And that is what I'm not close enough to the teaching today. But I would be most concerned if that's the basis on which our future clinicians are being trained.
Well, first, I couldn't agree with you more. Every revolution has negative side effects, and the fact that, so okay, we have this theoretical Tower of Babel back in the 60s and 70s. Psychoanalysts still kind of are influencing the manual mostly, but we've got biological psychiatry resurgent with psychotropic medications around the mid-century. We've got family therapy booming. We've got cognitive therapy, behavioral therapy, 3 flavors of psychoanalysis. I mean, so just going to the first part of your comment, it was a critical move when everybody was using different definitions of the same condition so that you couldn't have any accumulation of research to compare, to create a common lower level agreed thing we could point to and say, okay, this we all agree is this disorder, and now we're going to try our theories on a level playing field to account for this agreed phenomenon. So that was a big step forward. But the negative side effect is that as time goes on, means are mistaken for ends. The diagnostic criteria that were intended to help us identify and then develop some more sophisticated theories of conditions, they were never designed to be a substitute for case formulation. Whatever theory you have, that comes after diagnosis, after DSM diagnosis anyway. They were never intended to substitute for that, and Bob says that somewhere, that this isn't case formulation. But they get substituted and they get taught that way. And that's a horrible diminution of the richness of our discipline and what we need to know. And Bob would agree with that totally. He was solving certain problems. These are other problems, and many of us in the field, throw up our hands sometimes when we see what's happening with training as a result of reducing it to the common denominator of a DSM diagnosis.
Over there.
Thanks for the talk, Professor. I particularly liked the illustrated slides, so thank you for that. My question is that you mentioned that some categories can be created in kind of an arbitrary and theoretically motivated way, like childhood, for instance. And we determined that they are theoretically motivated against the concept of disorder. But when we recreate or when we do this conceptual analysis on the concept of disorder, what are we measuring that against so that we're sure that that isn't theoretically motivated as well?
Did you get the question? I'm not sure I quite got. Sorry, I'm not sure I quite got that. The concept of disorder is the grounding for the inclusion and exclusion in DSM, and at least in a theoretical sense. Different people can have different theories of that common grounding. Now you're asking, but if theories determine pathology, then how do we know the definition is better than the theory? Is that what you're asking? I'm not sure. I'm not quite sure.
I'm wondering that if the categories could be generated in this arbitrary way, right? Like childhood was one of the examples. Why couldn't a disorder, or surely a disorder, the theory of disorder, or concept of disorder, could be generated in an equally arbitrary way in order to justify the category? But if the category is determined to be fallacious in its relation to a theory of disorder, a concept of disorder.
No, but this sort of thing works its way, well, when you do research, this works its way out. I mean, this works, when you do research and you formulate theories and test them against data and test them in a Popperian spirit of looking for falsification and not just, confirmational data, then eventually you can't be as arbitrary as you're suggesting. You do end up weeding out theories and coming to some, and one of the things about arbitrariness is it throws construct validity to the wind. Basically, construct validity is what Robbins and Gouset were talking about back in 1970, and so you have all these convergent criteria for identifying something as a real entity or a real theoretically determined process. And so, over the long haul, the answer to your question is, it's the data. It's the data, stupid. It's like theory, and data will give us that, hopefully. Otherwise, we're in an eternal process of missing the truth. I don't believe in that.
Okay, I think we're at the end of our time. We're going to continue the discussion upstairs at lunch. So thank you very much for coming to this presentation.